Hello,
Hey,
everyone. Welcome back to Hot Seat Season 3. It's Omid Moghaddas joining you from Tehran. And once again, I'm so grateful and honored, as I always say it, to have the chance to be with you all through this platform with so many great, super talented clinicians from around the world who have a passion to share their knowledge, experience, and expertise with all of us and help everyone in this field to gain better knowledge and understanding in treating their patient. I think it's very, very valuable. And that's why at the beginning of every session, I try to say it over and over and over because, especially during this time around the world, which the practices are limited, we don't have enough chance to go to the symposiums, to the courses, to the congresses, at least internationally. It's very valuable that such clinicians and educators share their valuable time and expertise with so many of you guys. And I'm so glad that I had the chance to be a bridge between you guys and all these dear friends and educators from around the world. And today, our dear guest is one of the biggest bone builders from around the world. Dr. Pier Gallo is here with us. Hello, Pier, and welcome to Hot Seat.
hello, Omid. How are you doing?
Thank you so much for joining, my friend. As I said before the recording, it's absolute pleasure to have you, and I'm pretty sure you will be presenting a masterpiece for all of us, and there will be full of understanding about it. Actually, the topic that Pierre going to talk about is about vertical ridge augmentation in posterior mandible, which I believe, like most of you, it's one of maybe most demanding procedures in specific situations that we need to know about it. But at the same time, it's one of the most difficult procedures. And sometimes people say that vertical augmentation is not predictable, it's not possible. Maybe 10, 15 years ago, that sentence made sense. But nowadays, you see that it's absolutely predictable, but definitely is technique sensitive. It needs skills, it needs expertise, it needs practice. It's not something that you see on a video and tomorrow you go and do it, because there are so many things that you should take into considerations. You should know the anatomy. You should pay attention to every details. But I really want to say it before this presentation because I believe it's completely true that I can say, I'm pretty sure Pierre will talk about it, but we can say that vertical ridge augmentation is predictable nowadays, but the situation is not easy. So it's not something that 1, 2, 3. You should follow every principle, but you can make it. So, and so many people will talk about, okay, you build up the bone. So what will happen 4 years later? What will happen 10 years later? Will that bone stay or not? So this is one of the things that some people, maybe which are against vertical augmentation, will say that, they prefer to go with the short implants or leave the patient with the removable prosthesis or whatever. We want to say during this presentation that this is wrong, and complications can happen in every technique. It can happen in extraction, it can happen in vertical augmentation. So even if that happened, we should be able to manage the complication. And that is the main point that we want to make it clear. So I'm super excited for this presentation. I'm not going to wait you all much longer for that because I'm pretty sure Pierre will go in depth of a great case. But before we start, I would like to have a short CV of Dr. Gallo for all of you as a tradition of Hot Seat, and then we will continue to the presentation and we will have a great discussion at the end. Dr. Pier Gallo is a dentist and also a periodontist, national or international lecturer with clinical experience and education in soft tissue bone regeneration and dental implants. He received previous degree at University of Metropolitana in Barranquilla in Colombia, also the degree of Master in Periodontics, University of Latin America in Mexico, and fellowship in implant dentistry, University of Miami, Miller School of Medicine, Bogota, Colombia in 2012. Also training in vertical bone augmentation and soft tissue aesthetics, peri-implant and periodontal plastic surgery at Guide Institute, LA, and PhD in oral implantology, University of Sao Leopoldo. I don't know if I pronounced it right, in
Yep.
Brazil. So, my friend, once again, so thankful that you accepted. You're ready for your great presentation, and you can share your screen now.
Thank you, Amit. First of all, I would like to say that what you're doing in this platform to give this the opportunity to different clinicians around the world is a very valuable, very good. We need that platform. Thank you for the space and the time that you and the effort that you take of your personal time that I know that you take from your personal time to do that. Thank you for that, and I'm very honored to be here. I'm in Bogota, Colombia. I'm from Barranquilla, but I live in Bogota a few years ago, from few years ago, and we are here in the morning. We are starting the day. So I would like to share you a case that is very important for me. It has a lot of information and few things happen that learn me and teach me, and I learn from that case, and I take all that knowledge to share, because things happen, and the reality is that you can have this clinical case, and you can have very good results in vertical augmentation, but you need to have all the key factors in order to make a good clinical case in vertical augmentation. You said it is a very difficult technique, but it's not impossible. It's not impossible, but requires very good details that you have to feel 100% of that to have a very good result. And I didn't. So at the beginning, I learned a lot from this case, and I'm gonna show you a very common vertical defect that you need to gain vertical bone, vertical soft tissue, but you can have short implants as well. So you have two different options with implants, because you have the third option is a removable prosthesis, but you have in implants two options: do a vertical augmentation or do short implants. Which is better? We don't know. Why? Because there is a lack of evidence, a scientific evidence to compare, to show us which is better, you know? So you can do a vertical ridge augmentation and have a good result with the longer implants, or you can put shortest implant with a free gingival graft and have a very good long-term result. You have both the treatments, and you have to know that the patient decides. You have to give the patient the opportunity to decide. You cannot make your own clinical practice with your own clinical pictures that you want to do, and it's what I want to do, and I don't care if it's in your mouth. I want to do it. I want to do it, but I don't need it. I don't care. I want to do it. You know, so you cannot take your clinical practice to that level. You have to be honest and leave the patient to decide what is the best treatment for them. You know, for this patient, I did my best to convince him that he needs a vertical ridge augmentation, because I wanted to do a vertical ridge augmentation, because I like the technique. I like surgeries. I'm a periodontist. I am passionate of bone reconstruction. I really love that. So I told the patients, look, you can have a very good crowns with length of natural teeth, but you need to place the implant upper the bone level. So the implant is gonna be in the air, you know, it's gonna be in the air. So you have to reconstruct all the bone around those implants. So now we have one question: which is better, place the implant right now in the reconstruction surgery, or do it later? There is no information of what is better. But for the beginners like us, because we are beginners, you know, we're 41 years old, I'm 41 years old, so I'm a beginner. I prefer in just cases for the benefit of the patient, do it in both times. First the reconstruction, then the implant placement. So we have a lot of information and a very good information of meta-analysis and systematic review of comparing distraction osteogenics, inline blocks, osteogenics, distractions, what is said, GBR, blocks in online to gain vertical augmentation, and all that information conclude that guide bone regeneration is the most reliable technique in terms of bone stability, minor resorption, and low complication and rate of morbidity. That's a very good systematic review in treatment atrophic mandible, but we need long-term result to remain to be determined. So we have a update decision of vertical bone augmentation, and I like to focus in median defects, and it's a very recent research that came out this last month, I guess. In median defects between 5 and 8 millimeters, this technique is very predictable, but you can do short implants as well, you know. But this technique with titanium reinforced PTF membrane with autograft and bone substitute is a very reliable technique. We did a multicentric study with people from Peru that has a very good clinician and research. They invite me to do this case series of vertical augmentation that got published 3 years ago, and we gained an average bone of 5.44 millimeters. But look at 9 of 35 cases we had complication. So a complication happens to everyone. You can make a research that has a prospective study with 20, 30 cases and has no complication, but be aware that is not the true of everybody that had or going to do 30 vertical augmentation. That doctor is a very good clinician that in that 30 patient has no complication. But no one can say in this world that has 0% of complication in this technique. No one, you know, that happens. One of the things that you have to be very aware doing vertical augmentation is soft tissue management. From the beginning, selection the scalpel, selection the blade, selection the type of incision, selection how to manage the flap, the lingual flap and vestibular flap. So in posterior, it's very easy because you have 2 flaps to manage, lingual and vestibular. So you release both, and the suture without tension is very easy. But you have to train on that. But it's very easy. Trust me, it's very easy. If I can do it, everybody can do it. It's very easy. But you have to know where put the elevator to push the lingual flap. That's one of the keys, the important things to take care of that situation to avoid a complication. Then you have to place a membrane. So what happens if I use a titanium mesh? works and works very fine. The thing is not what you use. The thing is how to use it, you know, because you have a very good materials, but if you don't use it very well, it doesn't work, you know. So the thing is how to use it. So you can use Teflon membrane, you can use titanium mesh, whatever you can use, but it has to be for vertical resorbentation to from 5 to 8 millimeters, have to be non-resorbable barrier. You cannot use collagen membrane because you're gonna have a collapse, okay? So we use a Teflon membrane, we fix it in lingual with a Profix screws, and we use this mixer. I like to show this without any financial commercial, and they don't pay me for showing this, because this is a product in this case that you use allograft and PDGF growing factor. It's a growing factor, it's a synthetic growth factor that with the PDGF growth factor gain a lot of vital bone, vital tissue, and it's very useful, very good, but it's a little bit expensive. So that's not the bad thing of that, but it's very good when you have the opportunity to use it. Comparing with palatal rich plasma, palatal growth factor is a synthetic product and potential 300,000 times of PDGF compared what you can take from the patient. So it's a very good mixer without taking autogenous bone in that type of patient. It has very good research about it. Has Mark Nevins doing a very good research. Myron Nevis, Professor Urban show a case in very good clinical situation without taking autogenous bone. And so this is a case discussion. So this is a case report that I'm going to show you today. So I didn't use autogenous bone, so I fixed the membrane in vestibular with another Profix screw, and has the stability of the particles that it's thankful for the membrane and the Profix screw that remain stability of the particular graft. So now we're going to use a cytoplast suture to do the suture without any tension. So if you did the release of the flap in vestibular and in lingual, you're going to have a very good suture without tension, and it's very clear that if you can do a suture without tension, you will have no exposure. Now, you can have an infection, but no exposure. So infection is the other bad situation that can happen in this clinical situation, in this technique, that you can have an infection, but you treat it with antibiotics before and after, you know, but you have no exposure in posterior area if you treat the soft tissue very well. So that's one of the important things that you have to take care in your head. So this is the before and after with 2-month control. After 10 months, the patient shows, and we saw a little bit of suture, no problem if we have no pus and infection, you know, but sometimes leave a suture in this particular case can leave us an infection, and it happens to me before. So in this case, thanks God, we have no exposure. We open and we saw the soft tissue underneath the membrane. That is a soft tissue It's a healthy soft tissue with a lot of fibroblastic and very few vessels, blood vessels, very few blood vessels. We later times take this, we took this soft tissue out to see the bone, you know. But right now we leave the soft tissue without any problem because we know that that soft tissue is not a bad soft tissue. It's a very good soft tissue and can integrate with the periostic. But in the later times, we take this soft tissue out to see the bone and show that that technique promotes the bone formation. This is the before and after. We took a biopsy in the second implant right here. We placed 2 implants. We close. This is a panoramic control. And this is amazing. This is one of the pictures that I really love to share because you can see without taking any, I don't know why it's not possible to show these letters, but you can see here, let me show you here, you can see the real bone, the new bone formation around the particles of the allograft. And you can see the difference between the bone of the patient, the native bone, you know, the previous bone, and the new bone formation in vertical augmentation. And you can see 2 things. First of all, there's 2 different bone formation from the patient and the new bone formation. It's not the same and will never be the same. So that's one of the things that we have to keep in mind. Second, you cannot take a direct contact with the new bone and the native bone, you know? So always you're gonna find a soft tissue between the new bone and the old bone, if you can call old bone and new bone, or native bone and new bone. You're always gonna have a layer, a thin layer of soft tissue. When you can have a direct contact, when you start to do a lot of corticalization to leave the cells coming out from the medullary bone, and now you can have, with the histology, a direct contact with the new bone. So corticalization is very important, and I did not make a corticalization in this case, if you notice the previous photo. So that's 2 things that I'm going to share here. You can see the new bone and the integrate contact of the new bone around the particle. That calls osteoconductive. That's the real image of osteoconductive, the new bone around the particle bone. Okay, I'm not gonna bore you with all the histologic because I don't know a lot of histologic. I'm not histologic. I'm a clinician only. So this is a 5-month control. So we have a very good bone augmentation around implants. We have no bone remodeling from that time. We have all good, all things good. So we made a mistake. Why? We put the provisionals without doing a gingival graft to gain more keratinized gingiva or keratinized tissue. We did that mistake. We know right now the importance of improve the keratinization of the gingiva before you put the provisionalization. And this is one of the cases that shows us that and teaches that. So we made, after that, a very tiny gingival graft. That's the result 3 months after the gingival graft, but we have a lot of problems. Why? Because when you have the provisionalizations, when you have the provisionals and you make a gingival graft, a free gingival graft, you can only gain keratinized tissue in vestibular. you cannot gain in lingual, right? So that's another problem, because that's the 50% of the open door for getting bacteria from lingual. So look what happened. This is the X-ray control. We put the crowns 2 years, and I started to notice that this margin start to lose a little bit going apical. And I started, why can, so I think I'm gonna start losing bone. So I took a X-ray and look what happened. The doctor that made that restoration did not concern about the concept of platform switcher, platform switch. So he used a bigger prosthetic and keep a very bad prosthetic, so they start to getting more bacteria and getting more bacteria. I talked to him and I said, look, I do not do prosthetic. I only do surgery. So that's one of the things that I think I have to train myself, but I don't like prosthetic. I only do surgeries. So I talked to my colleague and I said, I'm not a prosthetic guy. So I think, in my very humble opinion, that I think this is not good. I think this rehabilitation is not good for the patient and for my bone that I just gained vertical bone. So please change it. Okay, he changed it, but the damage was done. Why? Because a lot of contamination getting into that area and fix it in the ruggedness of the implant. And this is a very bad situation from the long years coming on. So that it's a control of 3 years. Everything clinician was very good. And I was very proud of it and showing my curses. Look what I do. Look what I did with this case. 4 years, 5 years. And every year I noticed more bone resorption. And literature shows that you can have bone resorption in vertical augmentation for about 1.5 millimeters of 2 millimeters from 6 years and get stable through the years. But you cannot have every year more bone resorption than I was getting here in this case. And notice in this clinical a little bit of exudate purulent. So this is not good. And if you can see exudate purulent and you can see bone resorption, more bone resorption in your implant that just put in vertical augmentation, you have to do something. You have to treat it and rebuild everything again. So or how do you say, keratinized gingiva in lingua. Look at the lingual side. Look at how thin was the gingiva. And this is a very big open door from bacteria and from losing your bone that just get augmented by vertical augmentation. So this is a very difficult situation, and you have to remove your crowns and treat it. And look what happened when we remove the crowns, put a healing, and notice that in lingual was the exudate purulent. So what we do? So we have to open, clean, and start rebuild again. Okay, so this is what we do. We open, we remove all that granulomatous tissue. This is my protocol. It's not reported. It's not like in a journal. No, not yet, but this is what I do. I use a titanium brush. I use tetracycline. I use Pref gel from Straumann, and I clean it with a plastic cure. Okay, so I have to be sure that I leave the implant very clear. I do not like implantoplasty. Why? Because that implants, I was the guy for what I placed the implants. I was the guy who placed the implants, so I don't like to put to damage the structure of the implant doing implantoplastic. So I like to clean a little, clean a lot, clean a lot. Start to notice that we place a healing cover, a new cover, or a sterile cover. That's not new, but a sterile cover. We place it and we clean a lot and verify that there has no calculus, bacteria, and it's very difficult. That's one of the difficult part of implantology and treatment right now in 2021, how to clean and discontaminate implant surface. And if you talk to Maxim Simian, that is one of the fathers of vertical augmentation, he used a no roughness, a very, how do you say that? I'm going to look that here with my translator. He used
machine surface.
How do you say that?
Machine surface implant, machine surface.
Machine, that's it. A machine surface, in the top of the implant, he used a machine surface. If I can do that, it's better to clean a machine surface than a roughness surface, So that's common sense. That's common sense. So we have now in the market a machine surface in implants with 50% of machine surface implants. We have not that. So I use now in this clinical case, I use a tissue level implants from Straumann that has the machine surface in 2 millimeters or 2.8 millimeters. And I know that it's easier to clean that. So if you want to treat periimplantitis, this is the most difficult things, to gain a very discontaminated implant surface again. It would be very difficult, but you have to try it before taking the decision to extract the implant. Why I didn't extract the implants? First of all, because I'm gonna a little bit here. I have the 30%, 20% of bone resorption. If I had 50% or 60% of bone resorption of the implant, I take the implant out. But in this case, I only have 20%, 30%. So it's not a big deal. So you have to take the risk and try to rebuild that. So first of all, clean the implant. Second of all, I use autogenous bone, xenograft bone, and a product from Salbin that has a PDGF from placenta, So it's the product is called Anion, and it has PDGS, is palatal derivable growth factors from women to donate placentas. So we have a lot of growth factors in this syringe, and we mix it with autogenous bone and xenograft. We place, first of all, the autogenous bone in the surface of the implant, and then for the first contact with autogenous bone, that's a sandwich layer described by Homley One and Daniel Buser, that put the autogenous bone first, then the xenograft, mix it with the growth factors, in place a PDGF membrane. Now, we have to realize that if you don't want to do the same thing that we did 4 or 5 years ago, we have to rebuild what we need to rebuild. For example, I'm talking about soft tissue. I need soft tissue. I don't need only bone. I need soft tissue. So I take a free gingival graft, desepithelize the gingival graft, and place a connected tissue on top of the membrane, fix it with a resolvable suture, and start to close without tension, okay? To start to gain vertical height in soft tissue. That it's one of the things that we need. 2-month control, everything looks very good in the X-ray. Start the pandemic, so the patient lose 10 months for the next procedure. We like to wait 1 year for this type of bone augmentation because this is not 100% autogenous bone. Different from Curie technique that you can place according Curie, you can place implant in 4 months. In GBR technique, you have to wait a little bit longer because you have biomaterial. So you cannot be in rush to place the implant in 6 months or to open the membrane in 2 or 6 months. You have to wait. You have to be patient. So we wait 12 months to open. So we open and we do nothing. Why? Because if I put the healing screw here, the long healing screw, 3-5 millimeters, then it will be very difficult to gain keratinized tissue in lingual, and we're gonna fail again. So you have to do a different thing from what we did to correct and do it better in this time. Because when you do a technique and you have a complication, you have the opportunity to change it and do a little better, to do it better for the patient and for the case. So we close everything with the cover. We only did membrane removal and close everything. Now the periostic is going to vitalize this bone that is very important to the bone stability in the time. So we wait 6 months of that healing, but we need keratinized tissue. What we did is, look, the mucosa. So if I put all the provisionals, again, I'm gonna make the same error, and we're gonna fail again for the second time in this patient. So have to be very clear that all the research that talk about long terms, all research said keratinized tissue and periodontal maintenance could probably help achieve predictable long-term result. If you want to have long-term result in vertical augmentation, you have to be aware that the patient has to be very, very, very strict with their hygiene. You have to call the patient, and that's the very difficult part. I don't know how it is in Iran, but in Colombia, in South America, with our culture, people, it's not that, Swedish. That Swedish people is very like the clock and everything, have to be every 6 months. Here it's like, doctor, 6 months, I don't have the money for that. I feel very good, doctor, I feel very good. And when you see it 1 year later, start coming out every pus and then gallbladder infection, and then people start feeling very good. So in our culture, that's the hardest part, to maintain the case, to realize a patient that has to be very good patient, not only very good by paying the treatment. No, it's not that very good. That's important also, but it's not the only important thing. The important thing is that has to be very aware of the post-treatment, of the maintaining of those implants, because I mean, those implants will fail, will disappear, if he or she cannot come to the control visits and do a maintenance cleaning all over the years, at least one time per year. And the other situation is that every implant right now in 2020, every implant, every crown that you place in your patient have to be around a very good keratinized tissue. That's one of the biggest um, conclusions that came all through these years. We have studied implantology. That's the very good conclusion that you have to be. You have to have a very good keratinized tissue and has to be very good with the maintenance of those implants. And we did, in this case, a free gingival graft. I use this technique because I feel that it's the best technique. I don't mind the scar, I don't mind if I leave a scar, if the tissue is not the same color of the other tissue. I don't care really. Right now, the only thing I care is that I leave a very good keratinized tissue. Then 10 months later, why we wait so long? Because it's very difficult for the patient to come with the exactly time. With all this pandemic, this year was done last year, so it's very difficult to do the same month every treatment. But if you want to do little different things, I really like to wait long than to wait less. I don't know if I make that self clear. I like to wait more, than wait less. So I prefer that the patient comes in 10 months that wants to, in 1 month, do it everything. So I like to wait a lot. So the bone was stable after 1-2 years after the second reconstruction. I'm going to finish in very few slides. And this is the situation. You can see keratinized tissue in lingual, keratinized tissue in vestibular. So when we do the second stage surgery, we make a very tiny incision in both implants to change the cover from the healing abutment. Now, we notice that you have to be aware to leave keratinized tissue in lingual. You have to leave in lingual keratinized tissue. Look the keratinized tissue, and we place both healings. We change the healing for another wider or higher for 5 millimeters, and look how much tissue we gained in vertical augmentation of soft tissue. That's very important. And this is the final result. The same crowns, that's the same crowns, but locally lingual. So it's the same crowns, but in different reconstructions. So you can see 4 years, my vertical augmentation that I was so proud of it, and look at how you can make a very good reconstruction 7 years later. But locally lingual. So now I can sleep with my mind very calm. I can sleep good. I can feel that the patient, that those implants is gonna last forever almost, because has a very good tissue around them. So look at how we notice the 5 years control, and look at 7 years with the bone reconstruction. Look at the day 0 and 7 years later. So that was it, my friend. That's was it. Sorry to take a little more time that I supposed to do, but it's not easy when your second language is English, and I don't speak, I don't practice here in Colombia. So I try to do my best, and I hope that I make myself clear in every concept what I try to do. So thanks a lot, and I very anxious to have the discussion. Treat me well, my friend.
Thank you so much, Pierre. First of all, it was beautifully demonstrated. Everything was super clear, so no problem at all.
Perfect.
Yeah,
Perfect. Thank you.
it was, the photos were talking, and you also highlighted the importance, so everything was clear. And I think we will have a
Thank you.
very, very great discussion on that, because you mentioned so many great points, and so many great questions may come to so many people that want to try this technique or have tried this technique and have faced some complications and want to know your ideas. So, first of all the audience, these are the contact information of Dr. Gallo, and he's so generous to share. So if you want to get contact with him, these are the informations. And if you want to follow him on Instagram or on Facebook, to see beautiful sharing of his cases, so do it now, because you will learn, by seeing people's experiences, and especially the experts, you will get lots of ideas, at least to guide your patients. I always say that usually, I think in every country in the world is the same. Not all the patients are ours, but at least we can guide them. We can give them information so they can decide. So even if they chose to go to another practitioner, at least they know what we have said to them and what are the options.
What they put on their mouth. Yeah.
Exactly. So that's the minimum thing that we can do. And that's a great way of learning also, by seeing other people's experiences. So Pier, you can, if you want, you can stop share now, and we can have a discussion.
Yes. Wait, here? Perfect.
Yeah, perfect. So, you talked about so many great things. First of all, before going through your case, one of the things that I usually get question out of it, even in hot seat or in my courses, or everywhere, when the talk is on vertical augmentation, on the choose of the membrane, the size of the membrane, and most importantly, to shape the non-resorbable reinforced membrane. Some practitioners, usually their preference is to 3D print the cast of the patient and then shape the membrane on it. So on chair side, they will have very fast procedure by just putting the shaped membrane on the area. But imagine if I don't have the printer to 3D print the model, and I want to trim the membrane and shape the membrane, non-resorbable reinforced membranes, on the ridge. Do you have any recommendation for those who want to be better in this technique? Because sometimes they shape the membrane, but when they screw, the shape will change. And definitely that will affect the outcome that they will gain. So I want to know, first of all, before we go through the case, your recommendation on that.
Look, I'm drawing here. So you have two options. Posterior.
Yeah.
Posterior maxilla, right? Posterior mandible, right? Anterior mandible, anterior maxilla. That's the only two things. Why? Because you have to leave that excess of membrane one tooth later of the defect to fix it. Why? Because the right tooth of the defects, for example, a canine, the vestibular of that canine is your guidance or your guidelines to do a vestibular gain. You cannot do more than that because you're not gonna do a torus, exostasis, right? You're not gonna rebuild exostasis. So if you can put the membrane on touching the facial bone of the canine, for example, that's the only that's the volume that you really need for your implants, for your defect. So I always recommend in my courses that extend the membrane one tooth from the defect, from the vertical defect, gain the bond that you need in horizontal, because vertical, I mean, you have to leave it in crystal, you know, it's that easy. But in horizontal, that way you can rest the membrane on the size on the tooth across the defect without graft. Be careful, because if you put graft on the facial part of that tooth that you don't need it, you're gonna leave the membrane very high, and that you're gonna have an exposure. So you have to leave the membrane very good. There's two types of membrane if we talk about PTF membrane. 150. That's 150. That's how do I say that in English? That's 150 and 250. 150 is very tiny. The Teflon is very tiny, and the 250 is a very rich, very very thick. You know, one is very thin, and the other is very thick. The thin, the 100 type of membrane is for anterior area. That the biotype or the phenotype that is right now, the phenotype is very thin, to avoid exposure of the membrane. The membrane has to be very good, very good established, because you cannot have a edge that can leave a exposure. So you can always cut the membrane and leave the membrane in that round area without a edge that can leave an exposure of the tissue. Okay, so when we talk about the size, take care that you have, for example, there's a membrane of 30 by 40 millimeters. That's for three type of tooth, you know, three defects, three tooth of defect, or three implants of the defects. That's 25 per 20 for two tooth. And there's a buccal membrane that is only for one tooth. Be aware that you can't leave the titanium, okay, in the edge on the membrane, but that's not the thing of the membrane. So you have to trim the membrane and cut the membrane without leave any titanium in the edge of the membrane, because that could leave an exposure as well. No?
Yeah, I got it. So Pier, one of the things also you mentioned, actually you made it clear, because some clinicians like Marco Ronda, that had a publication, they want to place the implant exposed, and they do the vertical or GBR on top. And some people, I think most clinicians prefer to do it a stage. First build up the bone and then do the implant again. And me personally believing that stage is better, because in cases that exposure happens or complications happen, that implant surface and that roughness will lead the bacteria to go apically and make the bone graft completely contaminated. So you showed in your case that you build up a great amount of bone and you place your implant, and you showed during 5 years follow-up that some resorption happened. I noticed your radiography that you had about 2 to 3 millimeters of soft tissue thickness in panoramic view on top of your implants. So the crystal thickness of the tissue was not bad in your case. I mean, you didn't have attached gingiva that much, but the supracrystal tissue was not bad. But the resorption happened. So my question is this: for preventing that resorption, do you think that placing your implant about 2 millimeters subcrystally can help to prevent that bone loss, no matter if you do the attached gingival grafting or not?
Yeah, of course, definitely. That's a very good point. But I think also that if you have a bad rehabilitation, a bad selection of the abutment, you're gonna leave a very bad bone resorption in that particular case. So, I mean, despite of what you're saying that we don't have attached gingiva in vestibular like we did in the few years later, the thing that I think was the main important complication is the bad selection of the abutment. That was a platform switch implant.
Yeah.
If you use a wider abutment, you're gonna leave a space that is very difficult to clean, and that start the contamination. And when it starts, it's unbelievable difficult to stop it. You know, when it starts, the contamination is unbelievable difficult to stop it. So you have to remove the crown, change the abutment, open, and every surgery start to lose more bone and more tissue. So every surgery you have to put more bone, more tissue. Okay, now the crown. Oh, start push again. Take the crown, open, more tissue, more. So it's not easy.
You know, but what one of the things that you showed, your protocol was using the titanium brush and clean the implant surface and then put the graft on. So first of all, my question is this: do you think that with doing all these kind of stuffs, your graft material will attach to that exposed implant surface?
That's very good. And I think you know that the answer is no. There will be a soft tissue between the new bone and I don't believe, you know, my friend, I don't believe in the reosseointegration, you know? I don't believe that. I mean, it's very difficult, but at least what you're going to put in the surface that you get discontaminate, I mean, you think you get discontaminated, you know? It's not 100% sure. But at least when you put something in that implant, just get discontaminated, at least put autogenous bone.
Yeah.
Don't put 100% of biomaterial.
Exactly.
Yeah? So because that's worst.
Exactly. That was a great point because I wanted to discuss it also with you, and I'm so happy that you have also the same experience. But you know, speaking of the techniques to clean the surface of the implant, I had a talk with Georgios Kotsakis. I think you know him. He's from San Antonio, Texas, and recently published so many things on cleaning the implant surface. And they showed that the nylon brushes had significantly better results comparing to other techniques. And one of the standpoints was that in doing the implantoplasty or titanium brushes or any other things that remove the surface of the dental implants, the concern of those titanium particles in the tissue or in the bone is a concern for future changes. So my point is this: me personally have done many cases doing the implantoplasty, and my concept or rationale at that time was that, okay, I want to make sure that I'm eliminating as much as possible every contaminated implant, and I want to change my implant to a hybrid implant, so the exposed surface will become like machine, as you said, and the part is in the bone is like the normal implant. And you know, as you said, usually we don't believe in re-osseointegration. So the point is, it will act like a tissue level implant with a very high part of tissue level. So the only point is that the disease is stopped and we have kept the implant. So the reason that I asked this question and I opened this discussion this way was that because you showed that at least in radiography, the bone was there, you know, but we can say that it's not 100% attached to that surface. So, and also you used for the second time the non-resolvable membrane. So it's also a matter of cost. At least in my country, it's expensive. Those membranes are expensive. So the reason I'm asking this is not, I cannot say it's scientifically okay, but just a chat between two periodontists. I want to know, do you always prefer to clean the implant surface, graft, and put a membrane on top of it? Or in some cases, which the defect is not contained, it's horizontal, you prefer to clean and do the soft tissue graft alone and keep that implant stable like a hybrid implant. But with the tissue thickness, you're reducing the recession. Yeah, I want to know.
But you're going to leave the implant exposed, right? But the machine part.
Machine part, but with the soft tissue graft, we will cover it.
Exactly.
You know, it's not
okay.
The mouth, yeah.
That's a very excellent question because you leave me the opportunity to put two cases, two different scenarios. For example, one scenario, old lady that has no teeth and has 4 implants with a bone resorption and the name and hybrid prosthetic, you know? Okay, so you have that scenario. So in that scenario, if you lose bone and it's very difficult to rebuild because the patient will not lose her prosthesis, she won't take this prosthetic out. She won't be 12 months without tooth, without her prosthetics. In that particular case, I prefer to open, clean, discontaminate, do implantoplastic, no graft, and closed, and gain keratinized tissue with a free gingival graft, leaving the implant, a machine part of implant after the implantoplastic exposed to improve the cleaning of the patient.
Yeah.
But in a patient that has a very localized defects of 2, 3 implants, has all tooth in his mouth, all teeth in his mouth, and only need bone augmentation in 2 implants, I go to discontaminate and start to rebuild again to look for the final aesthetic. You know, to look for the final aesthetic. I know it's expensive. I know, but in this case, I took my guarantee. You know, what is my guarantee? My as a clinician, and I'm going to share it with you. My guarantee of this treatment is if the patient always come to a control visit 1 or 2 per year, I will treat it for free, but the patient have to pay the materials, the membrane, the bone, the growth factors. But I did not charge for my practice, for my surgery. You know, that's my guarantee. And I share always my guarantee with my students. I mean, it has to be about ethical, you know. If you do this type of surgeries that is very expensive, and the patient pay for it, at least giving a very good guarantee.
Yeah.
Right? A warranty. You know, it's warranty. I said it. I said it in Spanglish. You know, guarantee. It's not guarantee. It's warranty.
Yeah.
Okay, but you get it, right? So at least give a very good warranty because uh, the patient needs a more augmentation or a bone augmentation, soft tissue augmentation, do it for free.
Yeah.
Do it to keep the case perfect, to give the case a very good final result, you know?
Sure.
So if you treat it like that, it's not that expensive. Sorry to take you a lot of time.
No, what I wanted to also make clear is this. If we say that the new bone will not attach to that implant surface, so what's the difference between doing the implantoplasty or cleaning? Because even in implantoplasty, we have like a machine surface, it's a clean surface, and we can have a close contact between our graft material and the implant surface. So why do you prefer the decontamination process and not the implantoplasty, which seems to be faster and more, I mean, when you do the implantoplasty, at least you can be more sure that there is nothing left there.
Yeah. I mean, you leave a long epithelium, a periodontal epithelium, a long epithelium, that through the years, it will be very difficult to clean. Right?
Which scenario?
It will be very difficult.
In implantoplasty?
In implantoplastic. Because I imagine that implantoplastic with 100% of cover the machine part, right?
Yeah.
It's not the implantoplasty that the implant leave exposed, because I think it will be a disaster of the aesthetic.
Yeah.
If you take these implants, do the implantoplastic and put the crown, and through the years, the soft tissue is going to be down, and you're going to leave a very clean situation, you know, a very clean, but it's not a good aesthetic, you know, it's not aesthetic. So in that lady that has a very hybrid prosthetic, I don't care, because she has a pink ceramic. I mean, if she laughs, she will not show the roughness part of the implant, but a patient here, it will show a part of that machine.
Sure.
So I prefer.
Sorry. So you find better bone attachment to a decontaminated surface in comparison with the implantoplasty surface?
Yes. Despite of what I'm doing is not a reoscintegration, but the amount of vertical augmentation support the amount of vertical soft tissue, and we leave a crown that come out from the gingiva.
Yeah, that was a great point. I wanted to make that clear for the audience. And one of the also most important things that you also mentioned was the importance of the attached gingiva in the lingual side. So this was a case that you managed through the years. And I want to have your recommendation for our audience that they're starting to do a case and they see that there's not enough attached gingiva in the buccal, not enough attached gingiva in the lingual, and they have like 1 or 1.5 millimeter band in the crestal part only. So in the sequence, number 1, you prefer to do the soft tissue graft before your bone augmentation or after your bone augmentation?
After.
Number 2.
Why? Okay. Okay.
I'll ask the question and then you explain it. Yeah.
Sorry.
Yeah. Number 2, if you want to do it after the procedure, is it going to be before your prosthetic process or after? And what technique you prefer to make that gingival thickness? You place it like a saddle type of free gingival graft from buccal to the lingual, or you prefer to do the buccal graft and then move it to the lingual and keep half of it in the buccal? Which one is
exactly?
Yeah.
Okay. Thank you, because that's very good topic, and thanks for bringing it to the discussion. Because for the beginner, it has to be said that when you treat this type of procedure, if you don't leave the crown with a very good keratinized gingiva as well in vestibular as well as lingual, you're gonna through the year have a very unfortunately bad bone resorption that could fail the treatment. So I don't do the soft connective tissue before the vertical augmentation because you don't need it, right? If you don't need it, I mean, if I don't have hungry, I don't eat. You know, if I don't want to drink a beer, I don't drink a beer, right? So if you don't need it, you don't do it. Why you don't need it? Because you can close the flap with 100% of mucosa.
Yeah.
Okay, and it's easier to close the flap with the scar tissue done with a previous gingival graft. First of all. Second, a lot of research is coming out from long-term prospective results of what happened with the keratinized tissue, keratinized gingiva through a lot of bone augmentation. And there's a very interesting publication that said that when you have a keratinized tissue, every surgery that you do, you're gonna expect a stretch of that gingiva. So you're gonna lose a keratinized tissue every time you open and close the flap. Okay, so it's not important to do it before the bone augmentation if you know that you have to do 3 more surgeries. So you will done with a very tiny keratinized tissue. No, will not be the same that the previous that you gain after the bone augmentation. Then I do before the prosthetic part. Why? Because if you have the provisional in mouth or the final crown that is worst, because every surgery you will have a change of the marginal gingiva. Every surgery you will have a change. It will change. So if you put your final crowns and you put a gingival, all the vestibular incision will leave a contraction of the marginal. So you're going to lose height and you will expose the platform of the abutment, and it will cost you aesthetically point of view. So I do it before the prosthetic, because if you have the prosthetic mouth, you put the gingival in vestibular. So now, I mean, never you will have a keratinized gingiva in lingual, because you only have the opportunity to put the gingival in vestibular. So you will not improve lingual because only the surgery is in vestibular. So what I recommend, what I learned through the years is when you take the membrane out, put the implant, close again everything. Don't put the healing abutment, because you will lose the opportunity to gain keratinized tissue in gingiva. How you can gain keratinized tissue in gingiva is very difficult. It's very difficult because to gain keratinized tissue, you need stability. And lingual has no stability because of the thumb. So it's very difficult to put a graft in lingual and to get stable. So what we do is do the augmentation leave the keratinized tissue that you have. Don't lose it, leave it. If you have 2 millimeters, leave it in that position. Start the incision above that millimeter of keratinized tissue. Do the apical positional flap, a partial thickness flap, positional in apical part. Take the gingival graft. That is the best technique for keratinized tissue. The only thing is that leave a scar, and for anterior is a disaster. So in anterior, we prefer to use a connective tissue, a free connective tissue graft, instead of gingival graft. So in posterior, we put a gingival graft, and then when it gets madurated, very good through the month, 6 months, 7 months, whatever you want to wait. Don't wait 2 months, like book says. Wait a little bit longer. So when you le- do the incision, move the keratinized tissue that is on the crestal part, move it to lingual. How to move it? Easy. Change the cover for a healing, and the healing do the work. The healing move. That's it. You leave a part of gingiva, a keratinized gingiva, a thick keratinized gingiva in lingual. That's my recommendation for everybody that practice or have a case in posterior mandible.
That was a great point to mention. So I wanted to really make it clear because it's very important. And you know, I think we can talk about this for many hours, but I want to keep it short.
But let me go for a beer.
Yeah, yeah. I want to keep it short with my final comment, and want to know your idea, because I asked it from many clinicians, and actually I have a good experience on it. So just wanted to know your thoughts in areas that we have difficulties in fixation of the free gingival graft, even it's in lingual or sometimes in the posterior buccal or posterior mandible in the distal part. What is your experience in using, or in combination with sutures, using tags to fix the free gingival graft in those areas to make it stable faster?
Yeah, I mean, I'm old school. I think I'm an old school. I like to suture. I know that people put gingival graft and feet and everything, but I don't. First of all, that I have a question. Does fixation go through the bone?
Yeah.
Or it's only soft tissue? Go through the bone.
Go through the bone.
Why? Why you have to damage and do hurting to the bone to do a soft tissue destabilization?
No, I mean,
my first question.
Yeah. And you know, the point is that, for example, using a 4 millimeter tags, okay, so the gingival thickness of your graft is usually about 2 millimeters, okay? So about 2 millimeters.
1 millimeter the periosteum,
yeah,
and 1 millimeter through the bone.
Yeah. So it will
So
go.
it's not that damage, you know.
No,
it's only the idea.
And the fact was that not eliminating using the sutures, but for making a more proper adaptation, especially in huge grafts. I'm not saying about the little graft, in huge graft, and specifically in the areas that suturing is harder, like the lingual parts or the distal parts. Sometimes you don't have good access, at least for more amateur people. So wanted to know your experience, because I'm not doing it often, but I've tried it sometimes in situations that I wanted to just close the case faster, and it really works. So,
and that's tags. It's not a screw.
No, not a screws, not a screw.
Because the screw, it will rotate it, and will be a disaster.
Yeah, with just 2 taps, screws are the tags are very thin. So just about 1 or 2 millimeters go inside the bone, and about 10 days later, sometimes the tags comes out themselves, or you can remove them just by a pancet. So it's very easy, and you know, your surgery going to be faster, especially in difficult areas. So just wanted to know your thoughts.
Yeah, I think is every technique in all over the world, everything that we have to do has a lot of ways to do it.
Yeah.
You know, a lot of ways, and most of the time, those a lot of ways go in the same result. You know, go to the same result, but it's very difficult because in our practice, we have to do everything with an evidence based. You know, so a lot of things that came out in social media, Instagram, has a lack of evidence based. So you see the graph, and you see I don't know, a doctor, I don't know the name right now, but you see in Spain, I have a few friends that use that and put the pins. And I said, "Okay, that could help people who has no ability to suture.
Yeah.
You know,
Yeah.
if you have the ability to suture, I think you don't need it. I have no ability to put a pin to put it into the graft. So to get the ability, and this is I mean, this is very important. You have to train on it.
Yeah.
Everything you will do, you have to train on it. If you want to place a gingival graft with pin, please train of that. Don't do for the first time in a human being. Do for the first time in the animal model, in a course. Ask the people who have more experience what happened if you want to do it in the posterior area, and that force go through to the lateral bone of the sinus. What happened with that? I mean, you have to be trained of that. If you like to suture, do it with the suture. All the things that you do in your practice have to do with scientific based evidence and with a knowledge of people who have more experience than you and did it before you, and look the results of them.
Yeah.
So I think it's a lot of ways to do that, but the way that you choose, train on that.
Exactly. Exactly. Well, Pierre, I have to say thank you so much for sharing
No,
your
thanks to you,
valuable
my friend.
time and
I
your
really enjoy it.
experience. Me too, my friend. So really hope to meet you soon in person after the pandemic gets in control. And really
Oh, I
thankful
hope
again
so.
for sharing. Hats off, my friend, and keep it up. And all our dear audience, you can follow Dr. Pier Gallo's work on Facebook and Instagram. He's kind enough to share so many great cases for all of you, and you can learn from one of the best in ridge augmentation procedures. Thank you, Pierre. Hats off, and God bless you.
Thank you, Amit. Thank you for the work that you're doing. Thanks for the opportunity. God bless you. Stay safe and take care, my friend.
Thank you. Bye-bye.
Bye bye.